tables that people are still working very hard on their presentations. I can see it in people's eyes, okay? But if I could kindly ask everyone in the room to just take a small second to just pause and look up. We'll do this again if I can get 100% of eyes looking up. Excellent, okay. 100% of eyes, I can do it. Come on, I can wait here all day. Every group, measles, I'm looking at you now. Okay. Okay, Giovanni. Brilliant, okay. And the reason why I've asked everyone to look up is because I know every group here has been working incredibly hard this week, and the greatest kindness we can do for everyone over the next few hours is to, again, keep that energy up, be very present, and give everyone's presentations the full attention that they deserve. I know how hard everyone has been working and how much work has gone into these presentations. So please do give everyone the full attention, because there will also be the opportunity to ask questions and to better understand the tools that have been created this week. Okay. The format for the next few hours will be as follows. We will start with 3 presentations, followed by our tea and coffee break, as usual. Then the final 3 presentations, followed by a wrap-up, and then lunch. The format for each presentation was 20 minutes, of which 15 minutes is for the actual presentation, followed by 5 minutes for questions. Myself and Paula will be chairing the questions, and we will be timekeepers as well. Please make our lives easier by trying to stick to time as best as you can. Without any other delay, I would like to invite the first group up, which is the Data Quality and Validation team.
Okay, hi everybody. Good morning.
Yeah.
So this is the data quality and validation team.
So you don't block the slides.
Yes.
That's it.
So this is the data quality and validation team. Okay, that's Paul, and then there is Veronica, Manari, and Cosmas. There is Janet and Katie went, right?
Yeah.
Yeah. So our aim was to create an automated process to identify anomalies from the data submitted by KHIS. Maybe you can do the background.
Yeah. The format, yeah, I mean, we'll see as we go. So a bit of background on why we wanted to do this and why the Ministry of Health were interested in this project. So the Ministry of Health has some health indicators that help them track the progress of vaccine coverage, but occasionally they see data that just doesn't make any sense, things like over 100% rollout, and also sometimes they have no data and they have, like, for an entire month, there's a health facility that just hasn't reported it. And the reason those errors happen is because a lot of the reporting on the ground is like tracking on paper the number of people they vaccinated, like they just tick a box every time they do a new vaccination. And then they report all this in the computer at the end of the month, but in that flow there's chances for errors to get missed, or like they just flip 2 digits, they do like 91 instead of 19 or something like that. And so they wanted a way to sort of quickly identify the places where these errors could have happened, and first of all, then have a way to feed back to the health facilities and kind of ask them, like, maybe double check your paper records, and also fixing them in the short term so they can keep working. So yeah, so we wanted to have an automatic process so that they don't have to go and dig through all the data to find all the errors in a way that makes the data more useful for the ministry. So the kind of the three parts is, build just some analysis using some metrics, and then out of all the data for each facility, bring out a very high level score of the data quality, and then use the output of the metrics into a dashboard or to some kind of report that the Ministry of Health can use. And then consider how we want to substitute those missing values or erroneous values. And so this is the flow of the kind of data and process where the health facilities submit to KHIS, and then the Ministry of Health might process some data, and then this dashboard here in the middle, that's the dashboard that we've built, and that will flag up any anomalies. And then from these anomalies, they can do two things. They can either go back and contact the data providers, especially if it's like a recurring pattern of errors, then probably there's like something in the process that needs to be improved. And in the short term, they want to be able to continue working by sort of substituting those missing values. So I'll pass over to the overview of how the scoring works.
Okay, thank you, Paul, for that brief presentation on the flow of detecting or automated detection of outliers. And in particular case, we applied a statistical method to detect the outliers. And on this case, we follow the WHO guideline with the use of 3 standard deviation. And now we incorporated the interquartile range in case where the data is not normally distributed or non-parametric. And for this particular case, we conducted the analysis using R, and we utilized the data from the KHIS, and we opted also to have a comparative data from the Ministry of Health, which is now the Chanjo, which are in charge of the supply of the vaccines, so that we see the kind of a distribution of our usage of this immunization data. So with respect to the errors, it's normally we can get an underreporting or overreporting, where we can see again the completeness of this data, given that Paul has introduced well that facilities can easily capture the data at the end of the month, but now these tallies can happen in the sub-county level, reporting on what the facilities are doing, which may incorporate these errors. So one of the key things we were considering is the consistency, completeness, and the accuracy of our data. So the metrics, as I've said earlier, that we considered is over the last 12 months for each health facility, how are they reporting? And we applied the three standard deviation or the interquartile range. If, for example, the interquartile range lies below the lower bound 3 times that, or 1.5 times, or above the upper bound, that becomes an outlier, and it traces now the query where you get a feedback from the people, or they can quantify that. Over the reporting completeness, we also looked like an health facility may be reporting, but sometimes a vaccine, like a BCG, may be in a stock out. But what do we need to see? We can see like if they reported other vaccines, then that facility is not saying like they missed the reporting. Rather, there was no actual value, and that is why we needed a feedback where like we confirm from the facility. So we did a month-to-month comparison to see like how is the variation happening. And now look again the differences in the coverages for Chanjo data set and the immunization. But for this case, it's a work in progress in that we never managed to receive the data for the Chanjo data set from the ministry. This is the overall health facility score, where we developed now based on these metrics and comparison. We developed an overall score to see, using the traffic light, to say if it is an amber, that means there is something happening within this elder facility that needs to be checked. But when it is red, it is an alarm that you can use it to get feedback. The other thing is now when it is green, that means the elder facility is doing well. And this is how the overall score went through. Like, for example, a particular elder facility X, comparing in January, over these scores that we developed the metrics for each of the variable, they had 5 greens, 4 amber, and 3 red. But overall, their score will be amber, in that we still give a doubt, but this is upon now the policymakers to determine which they can use. On the second Y, we have 7 green, 3 amber, and 2 red, still in the amber position. It's not yet green. But in a situation, an elder facility having 9 amber, 9 green, 2 amber, and 1 red, that means that facility is doing well, and it is still subject to policy making regarding this third metric that it is showing a red, maybe in terms of completeness, or maybe in terms of the accuracy is not 100% the coverage. And that's why we gave an output like that. So I now invite Monari to take us on the ways of a short-term replacing of these values in case an LD policy needed to be met.
Okay, good morning once again. Okay, since we were dealing with data quality, now the major aspect is how do you deal with error with instances where you have missing data, where you have extraneous values, out of range values, and this is how we managed it. First of all, we loaded our data and then since we were using R, we used some of these packages like deplear or deploy. It depends where you come from, how you pronounce it. Then after loading the data, we filtered and cleaned the data. Since there were some instances where there were no data, so where there were missing data, it was marked by not applicable. And then we filtered for a particular county. We had 2 counties. We had the county Kiambu and Turkana. We chose those 2 counties. So in our case, we filtered out Kiambu County, maybe because of the population or something, and the cosmopolitan nature of it. Then we replaced the erroneous values in the columns which had erroneous values. We replaced them by setting out of range values. The out of range values, we subjected them to not applicable, because from there is when now we'll deal with the not applicable columns, the not applicable entries rather. Yes. So after we filtered out the out of range values, because we had 2 scenarios here, we have out of range values and we have instances where they were missing data. So out of range values, we also subject them to, I'm going to be as brief as a briefcase. Okay. So we added an error flag where we had flagged those out of range values. Then from there now we resorted to deal with to handle the missing now values. Now by replaying the not applicable columns, we use the mean. We had to take the mean of the columns and replacing them, because we assumed that the mean was the best. Then we merged the clean data by joining to the portion of the original bad data, because we were not supposed to alter the original data. So we merged the clean data. Now in our case, we are dealt with the missing data and out of range data. And then we saved the clean data. And that is how we managed to deal with the missing data and the erroneous data. And then there were some challenges. There were some challenges which we faced there. Like we had some health-seeking behaviors, population estimates. By virtue of time, I'm not going to explain because I was told to be briefer. Population estimates. Oh, I know you know how to read, so we can read. We can read together. We have so far achieved a small extracurricular change to that set, reporting rates and what the recipient of 16,000 health facilities only, 8,300 report on vaccine in administration, and these may not be representative of private or public health facilities which may affect healthcare seeking facility. I hope I was as short as a miniskirt. Others, thank you.
Okay, based on the outputs from the statisticians, we were able to come up with a dashboard to visualize the outliers and the data points. These are the two counties which we consider. That's Turkana and Kiambu. Let me just do. Yeah, this is the sample. Oops. As you can see, this is the sample output that we were able to generate based on the data that they provided to us. It was like, okay. After factoring all the scores based on the metrics that we were using to calculate, we were able to come up with these figures. Yeah. And the table itself to show the facilities with anomalies and without the anomalies. For this case, we are going to filter the facilities with anomalies so that we can be able to get the box plot. It was a way of detecting the outliers. So one could like select a facility and then we get the box plot of the selected facility output here down. This is for the 10 immunization, maybe vaccines offered administered to children at birth, maybe. That's the pentavalent 1, 2, MCV1, and OPV0. Yeah. As you can see, there are like outliers on the outliers are classified in red. The ones which are not outliers are in green, and then the amber ones are which are in between. Yeah. So this is the dashboard that we were able to come up with based on the output data that they provided. Yeah.
So I'm standing in for Dr. Hannah Kagiri from the Division of M&D. So they had sent in a request, as was presented in the introduction, that when they get into KHIS, they want a quick snapshot of the status of, let's say, indicators, healthcare utilization, vaccine coverage. But when they do so, sometimes the figures they get are just not realistic. Like they'll end up with 200% coverage. So within KHIS, there is a module where you can flag data quality issues, and they focus on outliers alone. But now with this, what I appreciate about what the team has done, they haven't just focused on outliers. They're looking to triangulate the data using other sources of data as well. So specific for vaccination, they're saying we have another data source, Chanjo, which tells you, let's say, the number of doses issued to a health facility. Then you can look at, with these numbers issued, when they say that they vaccinated, 1,000, is it realistic? So then, also by creating the score, you can rank, what is likely to be, really off versus something that's only slightly off. And if you needed to prioritize, then you could prioritize those that are scoring higher, in the sense that you think this is an anomaly, because from several data sources, it's showing as an anomaly. It wasn't presented here, but really the end result is if we could impute for the data that's missing and the data that's, we know is wrong, as was mentioned. Let's say a health facility has been going around 19, 20, 22 children vaccinated. Then on the month that they were supposed to write 19, they write 91. If we could, get, impute that value, because we've picked it up as this is likely to be a wrong value. I think that's still work in progress. But the idea is that now with a click of a button, the MOH could have two sets of values. The values as it is from KHIS with no data cleaning, and then another value where we've picked up the outliers, we've replaced them with what we think is more reasonable values to get a more accurate estimation of, let's say, vaccine coverage. So thank you to the team.
Okay, please. Okay, I'll be quick. Mine is just a summary of what you should expect from us. So you'll hear a repetition of what everyone else has talked about, because we're majorly just talking about these are the challenges we faced, so how are we going to counter them? And this is what we were able to cover. So we didn't cover this and this, so how are we going to approach that? So the first step is to incorporate the Chanjo dataset as a comparator. So you had there was a bit of mention on Chanjo dataset, but what we got was just, to quote what my colleague said, an extract of what we expected. So once we get the rest of the data set, we can use it to compare the stock and maybe the immunization. An example is the stock and maybe the immunization that is given in a specific facility, and how that compares and how we can use it for data quality. The second one is to examine the coverages through incorporating demographic information. So my colleague mentioned that we are only able to tackle the Kiambu and the Turkana counties. So one of the things that we should check out is adding the rest of the counties, and maybe any other information that, information or variables that might vary in those counties, and see how we can make the quality a lot better. So the third one is adding other indicators other than immunization. So we are basically just dealing with immunization vaccines, and we'll be able to add other diseases, think measles and the rest. And so iterate on the scoring metrics with the policymakers. So my colleague presented on what we were using. We were using the standard deviation, the IQR, and we were setting specific numbers so that we can be able to flag it either green or amber or red. So is that okay? And we'll have to discuss this with the policymakers so that we can come up with a better scoring system. And then we're going to refine the visualization. And we're also considering adding AI models. Can we build models that can be able to predict these anomalies in certain places? So yeah.
Thank you. I think Paula is so conscious about the time. And now the next step is about the maintenance, where SEMA will be incorporating and doing the same with the Ministry of Health. Thank you.
What we'll do is, just as a heads up, we won't have any questions because of the timing. What we will have is one question, which is, in 10 seconds, can you summarize your maintenance plan?
Okay, great. Anthony and I will be also continuing working on the data and improving the data quality in the department, and also looking forward to hear from the monitoring and evaluation team from the Ministry of Health to see how we can improve our data to make our policy making. And especially, we're waiting for the community health promoters data, which is a confirmatory of, I think that will be the best data to work on also to incorporate on this. Thank you.
You're good.
we're not taking any more questions.
No.
Okay.
Who was next?
So I think that because this was the first group and they volunteered to be the first group, they got a bit more time. We will be 30 seconds will be 30 seconds and 5 minutes will be 5 minutes, no more. Animal surveillance, do you want to go next? Yes.
Yeah.
Purity,
We-
are you?
Animal surveillance, come up to the podium.
Is Tumbi in the room? Is Tumbi in the room?
No.
No, I can't see him. Sorry. Sorry.
Excellent. Can we have a round of applause to welcome up animal surveillance?
To connect yako. To connect yako.
Connect aje?
You guys.
Sasa kuna place nyingine ya kupresent ama ni overview pekee?
Ni map of the work tumefanya alafu tuingie into details. Na make sense?
Sawa.
Mine does not have that one.
Brian, does your laptop have
Yes, you have HDMI. HDMI.
I think. Okay. Wait, Brian, I think we've got it.
No, Ryan should connect. Let her laptop.
Okay, hi everyone. Good morning. So before you is a group that was handling animal health surveillance. And I hope over the course of the week you got to interact with everyone here on my team, either over lunch or tea, so I'll not mention their names. And if you didn't get a chance, for our visitors today, please ensure you interact with these amazing people.
Okay, awesome.
Okay, sorry for that. I hope I have your attention back. So this team was handling animal health surveillance. And we are happy to present what we have been working on throughout the week, and I hope it will be worth the effort. So I'll give a brief background to the problem we were tackling. So this was a call for help, or a call a cry of help from the Directorate of Veterinary Services. At the directorate is part of the Ministry of Agriculture and Livestock Development, and the epidemiology section, as we were doing our annual work plan, we realized that our data management was quite, I can say, in a crisis. And a brief background to this is that data in the animal health sector, we use the tool called CABS. CABS in full is the Kenya Animal Biosurveillance System. This is an electronic tool that was developed in 2018, mainly for reporting animal health events. So be it occurrences of diseases, be it when we have outbreaks. Sometimes we use this for vaccinations, when we carry out vaccinations in the community. And we realized that CABS was handling data from various sources, and we didn't have a way of integrating the various sources, data received from the various sources, and as well as automating, cleaning, and analysis of the data received by CABS. So that's why the directorate sought to create to have a platform that consolidates and automates animal health data processing, analysis, as well as dissemination. So we hoped that by integrating CABS and other CABS data and other relevant data sets to give us comprehensive and real-time view of animal health, so that policymakers are able to carry out timely interventions and give informed decision making. So I'll take it back to the text to carry us through what they did.
Hello, everyone. This is an overview of the work we have done. First, we get the data from the sources, including the labs, research organization, clinics, county government, and other designated areas for veterinary services. Then it gets to the data hub, the one you said, KABS. Then there is automated data cleaning to the database, which our team managed to come up with. Then there is data analysis and then mapping, where we, okay, thank you. We managed to come up with different visualization, which will be shown later on, that reports maybe priority disease, which one has the number of cases at risk and infections, also distribution across all the counties, then reporting to decision makers and policy makers if the objective they had set to achieve from the data has been achieved or not. Then from there, it's the role of the policy makers to give feedback to where the data came from. Thank you. Allow me to welcome the technical.
Thank you, Arani, for the overview. So I'll just provide a deep analysis, a deep overview of what Arani has said. So basically, in the automated data cleaning processes, we managed to source the data from the CABS. Sorry, we were able to source the data from CABS and create a data cleaning script, so that when the data is exported from the CABS and enters into our database, which I'll explain later, it will be able to be cleaned and stored in the database. So in the next step was the database, where our database currently is hosted in the AWS cloud. So after the data is stored in the AWS, we'll be incorporating an endpoint so that it will be able to attach from the database to our dashboard to incorporate a real-time analysis from the data collected from the CABS system. So Later, after data is collected from is stored from the database and then fetched into the dashboard, we'll provide the visualization, which Anne will provide with the demo. Just give us a few minutes.
Local. Hey, young. Oh, we are sorry. We are really sorry. Fungwa, local. Yes.
Cool. For technical reasons, we are going to bring forward the tea break. But before we break the tea, could I actually invite Tumbi and Lois up to give an introduction and to welcome them to the day as well? No, it's okay. You can take the tea break. Okay, cool. Yeah, from the front, so everyone can see you. Whichever one you like.
Okay. Good morning, everyone. Day 5 and people are still smiling. You must have done something right. So I think it's just really a pleasure to see everyone here. It's unfortunate we're not able to join from the beginning, but better late than never, right? So I think it's to welcome you to the training. This was a speech of day 1, so we're still giving it anyway. But it's really good to see all of you. We're very grateful to Paula, Jeanette, and the rest of the team who've been working around the clock to try and organize this hackathon. For the team from Imperial College, welcome to Nairobi. We're really looking forward to spending a bit more time, but it's really good to see you all. And to everyone who's participated, I think particularly people from all the ministries, from government who are eager to use data to inform policy. I think it feels good to be in a country where people are using data to inform policy, amongst other things. But we're glad that, the ministries have engaged so well and are eager to use this data. I think even just listening to the first 2 presentations, we really appreciate the place of having data in the first place, having good data, clean data that's of good quality and that is accurate. And I think from SEMA perspective, it's really just to continue to support that process. We don't always have the knowledge, the skills and all, but I think the main thing is that we're willing to learn, we're willing to collaborate and to continue to support this. I think I was asked to introduce myself. Is that what I was asked to do? So I've done everything I wasn't asked to do. My name is Lois Sombajo. I'm a physician, infectious disease specialist, getting lost in data most of the time, but I co-direct SEMA with Umbi. So we're from the University of Nairobi, and it's good to see you all. Introduce yourself, follow the script.
In Kenya, we say all protocols observed. Good morning. Thumbi Mwangi, as Lois mentioned, we co-direct the Center for Epidemiological Modeling Analysis together. It's a real pleasure to see all of you. I'm already so much enjoying the hacks. So maybe I should just let you have tea, and then we can give you the congratulations message much later. But thank you and welcome.
Okay, so I think we will have a 15-minute tea break and then proceed with the animal surveillance team and then have all presentations in one run after that. Mizets, please. The stage is yours. A round of applause, please, for Mizets. Come on, Mizets. So to me, Lois, I don't know if you're in the room yet, to me. So we call each other families. So this is the Mizets family. Mizets family.
Giovanni, Pius, Salmon, um, Patel, Ivy. Okay. So we were working on measles outbreak in Kenya. Measles is the most infectious viral disease, and it's common in children under 5, although everybody can get it. Vaccine is the most effective prevention, and in Kenya we have 2 doses. The first given at 9 months, the measles and rubella 1, and the second at 18 months. Outbreaks in Kenya are still an issue, and measles is endemic in Kenya, and the outbreaks are usually localized, that we will see in the next slide. How the government tackles this is by having the supplemental immunization activities, which are a good intervention to curbing the spread. The challenges we were given by the decision makers when we were consulting were that measles is severely underreported. There's usually the issue of missing information in the case surveillance database, and there is a need for efficient SIA planning because of limited resources and the need to make a high impact. Our approach was to come up with a data dashboard and a transmission model, which we will show later. So we are hoping that when this exercise is completed, we will have information to inform outbreak risk so that we have a pre-planning report. We also have the ability to inform intervention planning, so how to target the SIAs, at which regions, to which age groups, and so on, and to assess the intervention impact. Now that is post-planning. The sources of data we have are weekly case-based data from the surveillance system, which was adopted in Kenya in 2002. And we also have vaccine coverage data yearly at the county level from the vaccine immunization program. So here the national picture. In Kenya, the MR1, the first dose, has very high coverage over the years, above 80%. And since its introduction, MR2 has also been increasing steadily. Kenya has conducted a total of 12 SIAs since 1994 with high coverage. For the subnational picture, what we have here is a chart showing you on the x-axis the coverage, the vaccine coverage for the first dose, and on the y-axis the vaccine coverage for the second dose. And then the size of the bubble is the incidence rate per 100K population in Kenya. So something we can say is in counties where there's very high coverage for both the first and second dose, such as Kirinyaga, Makueni, and Machakos, in those counties the incidence is also very low, except for a few cases such as Garissa in 2024, where the coverage is almost above 100%. You remember the data quality team showed us sometimes the coverage can exceed 100%. But the incidence is also very high in those regions. If we are to look at the spatial aspect of measles incidence at the sub-county level, there is a huge problem in the northeastern part of Kenya, and that is mostly because of migration of refugees from neighboring countries and low vaccine coverage in those areas. So at this point, I'll give my teammate Pius to come.
Okay, thank you, Stanley. So we worked on, just to do a bit more of EDA, we worked on a dashboard. We used Apache Superset, which is an open source tool from Airbnb. We have some tree maps, some pie charts, some line graphs, just to show, yeah, I think we've gotten the question whether the dashboard is real a few times today. So let's just prove that it's real. So yeah, there's our dashboard. You can see we have, nice, okay. So yeah, we have some filters. We have filters by sub-county, by age group. So we have like 1 to 4, 10 to 14, under 1 year. We have categories after the tests. We have compatible, negative lab, confirmed, pending. Yeah, and also by counties. So this is one of the graphs that we could show. Let's go full screen. So you can see that the Dab refugee camp is one of the most affected counties. I don't know, sorry about the but that is Dadaab. I don't know if you can see clearly, but that is Dadaab with one of the biggest number of cases, 22.37% of what we have here. Then we have Turkana, Kajiado. Yeah, that's just one of the visualizations we have. We have a time series by sub-county to see the number of cases as the years go by. So let's just apply a filter to this. Let's see what happens. Nice, yeah. So that the cases in this is Wajir County from July of 2023 to 2025 January. Yeah. Then these are vaccine coverage chart of MR1 and MR2. So as you can see, there's been a bit of the difference when MR2. This is MR1. The vaccine you get at 9 months, I think, and this is the one you get at 18 months. So when it started, the difference was very big, but I think it's gotten better. But there's been, I think, a bit of stagnation as time has gone by. This is 2022. Yeah. And then we have a pie chart for cases by age group. This is for Wajir County. I'll just show this. I'll just in the 8 minutes. Okay, so you see the most affected age group, most times it's 1 to 4 years, and then 5 to 9 years follows close by. Yeah. Okay, and I guess that's it. Yeah. Guess I'll invite Amika to come and speak about the transmission model. Thank you.
Thank you, Pius. Hi, everyone. So based on our previous challenges and demonstrations, we've come up with a measles transmission model, which is age-structured, and it incorporates the transmission dynamics as well as vaccination. So vaccination, we've included both the routine doses as well as SIA campaigns. So just to look at the transmission dynamics initially, we've got 4 compartments. We've got our susceptible individuals. These are individuals who can get the disease. Then we've got our exposed individuals, our infectious individuals, and our recovered individuals. So you can enter into the susceptible stage through birth, and you can leave it either through natural death, or you can be exposed to the disease and then move to the latent stage, which is the exposed category. Then you can leave the exposed category either again through natural death, or you can move to the infectious stage. Now from the infectious stage, again, you can leave through natural death, or you can gain immunity and recover. Now this is just the transmission dynamics. Including the vaccinated portion, you can get the first vaccine dose and move to the V category, or you can either get these doses through the routine dose, the first routine dose, or you can be targeted through an SIA campaign. Then once you're in the vaccinated group, you can, if you get your second dose or you're targeted again with another SIA campaign, you've gained full immunity and you move to the recovered stage. But if you get exposed to the disease before getting the second dose, you can move to the exposed stage and then again go through the infectious period and then recover. We also have the exposed proportion who can be targeted by the SIA campaign, and they can gain immunity and recover. So we imputed these dynamics as stochastic differential equations in Python and came up with some examples of simulations. So if we were to initially ignore any vaccination coverage, we are just looking at the population dynamics of the susceptibles, exposed, infectious, and recovered. So initially, we assumed we just have about 999 susceptibles and 1 infected. All the rest of the populations are set to 0. And we've included a seasonal component to our transmission dynamics as well. So initially, you see as the susceptible population goes down, they're moving to the exposed. And then you'll notice that the exposed, which is the yellow graph, starts to increase. And then as they move from the exposed to the infectious, you'll start to see an increase in the recovered, which is the green graph. And as they move from the recovered to the infectious, you'll start to see an increase in the red graph, which is the infected population. And because of the seasonality, you'll see that as one population decreases, another one will increase. Now, in introducing vaccination coverage, we wanted to show the incidence rates without the coverage and including a coverage. So if the first blue line is where there is absolutely no coverage, no first dose, second dose, or no SI campaigns, we see that we've got a high incidence rate, about 0.8 onwards. But looking at the second graph, we introduced a small coverage for the first dose, which is about 40%, and then we varied the second dose. So if we look at the first light pink at the top, 0.0, this is when we don't have the second dose. We just have the first dose. We see we've got about 0.5 varying incidence rate. But then increasing that coverage, as you go downwards, we see that our incidence rate decreases. So now I will introduce Giovanni and Salman to give more theory behind the calibration of the model.
So we used Bayes' equation for the calibration. So we were taking like the probability of theta in D. So in our case, we were doing theta, we called it beta. It was like for the vaccine coverage. And like D, we were like using, no, our beta was, sorry. Our beta was contact, and the D we used like the vaccine coverage. So for we equated like the probability for to the prior and the likelihood, the evidence of it. So we used beta for coverage, and we used like for theta, we used what was it called? Yeah, from the code.
We set a prior on beta?
Yeah, prior on beta. Yeah, so like basically we use like the calibration for the parameters to get like the simulation. Yeah, so like with simulation and modeling, and then we tested it. Yeah.
I'll try and whiz through quite quickly. So to estimate this posterior, we used a recent method called flow matching, where you learn a way to transform a simple tractable distribution, like the Gaussian distribution, into your posterior. So one of the benefits of this is that it allows for quick sampling compared to more traditional methods like MCMC, like you might be familiar with, and it is less likely to get lost when sampling the posterior space, especially when we have this SDE, which provides stochastic outputs. These are some calibrations which we did to some case data from Nairobi, which is generously given by the Ministry of Health. It's on a weekly timescale. The data starts at 2019, and Normally you'd have a better warm-up. This one's just 1 year long. But you can see the prior fit is on the left and then the posterior fit is on the right. It does start to find the seasonal trends and calibrate the overall burden, this beta parameter that Simon introduced earlier. And it can start to give us a reasonable projection for incidents in the next years. So in the interest of time, there's some more plots. Yeah, I don't know what's next. We're going to have next steps. Would you like to go?
Sorry, good morning, everyone. Florence is my name from the Ministry of Health. So far, so good. Let me congratulate this team. They are on the right track. They are on the right track because they are answering our gap. Whatever that they have done is going to assist the program in planning for SIAs, knowing the target that's supposed to be used and also the risk areas. So as much as the work is still on progress, I'm sure that the outcome of this analyzed data is going to help the ministry in a great way. Thank you so much.
How I'm planning to take the work forward would be to ensure we continue to collaborate with the team. I will not prefer to do it alone, so I'll be in contact with everyone so that we ensure we take it to completion. I think that's fine. Okay, thanks.
We will have questions for 5 minutes. Are there any questions in the room?
I'm curious about flow matching. How does that work? How is that different from MCMC?
So flow matching will come under variational inference methods, where you parameterize a tractable distribution to match your posterior distribution, your target distribution. Whereas MCMC more draws samples and then moves in the vicinity to more likely samples in that area. So with MCMC, it has, you often have issues of, it might get lost in a local area and you have parallel tempering and all these gradient-based methods to try and overcome that. In variational inference, you have approximation issues where you try and get lots of samples from the model and you try and create a posterior that really matches the data that you're seeing, but it's just an approximation. There are no samples that are being run through the model at the posterior sampling time. So yeah, there are some trade-offs between them. What you would do, there are good metrics like the Bayesian predictive value, where you can see your observational data and how calibrated your posterior is. So if you are very tightly, if your posterior is very tight around your observational data, it might not make lots of sense. There are also metrics like L2CST, the local two-sample classifier test, which is made just for flow matching, which can very efficiently give you estimates for how accurate your posterior estimate is. And then if it's too low, you just put more samples, because you do have a model where you can just make more samples, so overfitting isn't as big an issue as if you were training a normal machine learning model on a limited set of data. You have infinite data, so it's less of an issue.
Yep.
Thank you.
Toby?
Good question.
About like estimates that are sub-regional, like should we say we should improve our vaccination rates in specific places as opposed to the entire country? Like how do we plan for that from your work?
The methods we have applied to the dashboard does have filtering by county and sub-county. The fit we did was to the Nairobi County because we want a reasonable amount of data to make reasonable assumptions. And at the sub-county level, we still need to do more analysis to see if there is enough data to make reliable inferences. So the only limitation is really the reporting on the sub-national level, on the sub-county level. Yeah.
Yeah.
So you said your susceptible population, everybody born, then you had your, you want to know your exposed population. Where are you getting data on your exposed population? What data are you using for that?
So for our dynamics, we just simulated some numbers, and from the current data we have, which is the case data, we just have the positive infected population. So we're hoping to run our model for a period to get a sort of idea of what our infected population looks like, and accordingly what our exposed could look like as well, to get some estimates.
Yeah, we have one last question on the side.
Yeah, thanks to the team, and I'll speak from the ministry perspective. So, from the policy perspective, us will not listen to Bayesian inferences and all these things. Flow matching, all this. So this for you, the technical people, to look at and validate your methods and all that. But from the ministry perspective, what we then need is, we need to have proper estimates of our burden of measles as a priority. Then the issues around intervention planning. We know that for measles, the main intervention is really vaccination. Maybe we can add the issue of vitamin A, particularly to prevent mortality in the infected groups. The model you've developed seems okay. And also the granulation of the data is also important. So for us, the key thing from the ministry, usually for measles, we want the routine immunization coverage. Where are we not meeting our target of 95%? What should we do to achieve that target? That's the first question. 2, we usually have periodic campaigns, often every 3 years, 3 to 6 years or so. And what we want to track is the cumulative number of susceptibles in that period. So that's something we also need to track. And then to look at the susceptible population at any one time and make that a basis for a risk mapping and campaign planning. So a lot of that is coming through the work you've presented, but now package it for policy and decision making so that it is easy to arrive at. We were not given an opportunity to respond to the DQA presentation, but it feeds into this work also. So if you allow, the validity of the data you're using in the model will also be affected by those DQA issues. And if we are allowed at one time to speak to it, we can also say one or two things around it, because that data guides you in the determination of outbreak thresholds. It determines how you target even the campaigns for various diseases. Thank you.
Thank you very much. Yeah, if there are other questions you want to ask to the quality and validation data team, do you have anything that you want to cover now?
So for the data quality team, there are issues around flagging, which is an important bit. So you're just using normal distributions, but the metrics you're using, I saw you're using IQRs, you could still use SDs, and many other mechanisms. But what is important, after you flagged, you see that information is supposed to get to the data entry personnel. So you are providing support supervision to the person entering data. Once you flag it out, it should be corrected at the sub-county level. But the other thing is that if you get coverage of more than 100%, it does not necessarily mean that it is wrong. It could be a denominator issue. So if, say, you have to triangulate some of this data to be able to make sense of it. If, for example, you are looking at vaccination coverage, you can also triangulate with the commodity data. You can also look at outpatient service data to be able to come out with estimates, because we know the challenges we have with our population denominators. The other issue, of course, when you get that anomaly, it could be, if it is disease cases, could be an indicator of an outbreak. And that's why we use thresholds. So that flagging mechanism should lead to an investigation if there are disease cases. Finally, there are also issues around, I know you talked of Chanjo. Chanjo has its governmental issues, but you can use other service indicators to validate what you're doing. But what you now need to tell the team at MOH, based on what you've come up with, is this should lead to a data quality improvement plan. So what are you proposing in terms of a policy brief towards the ministry?
Thank you so much. I think this is incredibly helpful to take this work forward afterwards. Francis, you're presenting next as well. So.
Thank you, Team Misos. So my small question is about the threshold. When we started on Monday, we were hoping that the team was to come up with what is the threshold to determine an outbreak. I've not heard it from you. So did your model give us a certain threshold which you can believe in?
So yes, that was one of the questions that was posed by the decision makers. And so there is a threshold that exists, and the question was whether it is sufficient. So it's at the back burner for now because we don't have enough data to quantify what happens after that threshold has been initiated. So it would be difficult to then work backwards to find out whether it was enough or not. So that's why we prioritize this other bit. But as we get more information and we talk more to our decision makers, then we might be able to answer that question as part of future plans.
Speaking into the mic for the online audience.
Let's give this Misits group, Misits family, a round of applause. Really well done. I think we're moving over to the HR family now. Let's keep it to 15 minutes.
I forgot to put the motivation out. There are biscuits for the first group to stick to 15 minutes, if that helps.
Okay, so that might be it. Happy days. Right, I'll hand over.
Good morning, everybody. For us, this has been the most interesting theme. You know, it's a theme that was not included in the themes that were supposed to be done, but having come up with this particular theme, it's been an amazing journey for all of us. So we were looking at the human resources, and those are the beautiful and handsome men and women behind the work that has been done. You can see them, the photos also suggest. Now, having said that, we clearly, right from the beginning, we did have an understanding of the prevailing circumstances and challenges that we have with regard to human resources for health in this country. It is also informed by what's going on around the globe, and especially in sub-Saharan Africa. We do recognize that in the constitution of this country, health is a human right. But as a result of having challenges with regard to human resources for health, then it gives us an opportunity to find out what we need to do to inform policy and decision making. Also in the current government, they have the bottom-up economic transformative agenda on human resource, which is a major pillar for them. Now, having said that, from the local context, in the World Health Assembly, we do understand that this is also an issue that is of concern. We need to promote health and well-being for all, and we can only do that if we can strengthen human resources for health, which is such a strong pillar as far as the pillars of health systems is concerned. In the Agenda 2063 of the Africa Union, I shared right from the beginning that this is what is now being spoken about, and for us to achieve that, then there is need for us to look at how can we develop the human resources for health so that we can be able to reduce mortalities and morbidities that are resulting from that. We have challenges, skills in terms of shortage skills and even distribution when it comes to urban and rural regions. We have limited capacity and financing. We have now a triple burden. And that's why someone has been saying a month or two will not pass without seeing the health workers striking in this country, for example. And of course, augmented with the rapid population growth and the brain drain that we all know that is such a major challenge in sub-Saharan Africa and in this perspective in Kenya, for example. So our major goal was to ensure that there is sustainable investment for health workforce, and how can we optimize that to ensure that health workforce in Kenya really is helping us to achieve the universal health coverage. Our objectives were to create a proof of concept, at the count level as far as the dashboard for HIV is concerned. So we were thinking of all the diseases, but also the top 10 diseases, but we had to narrow down because of limited time. We narrowed down to HIV and AIDS. So how can we quantify the extent of the current unmet needs? And how can we ensure that we have aligned efforts, from the presidential task force on HRH reforms so that we can be able to work together as a team? And this has to be done from the perspective of the data and the evidences that we have. Thank you.
So what you're seeing in front of you is what our approach was. And we took disease burden, and this is now by county. And we've used HIV as an exemplar, but this is a process flow for all the diseases that will end up being included in the model, which we expect to be at least over 90% of the burden. So number needing care, and we then estimated the time resource required per patient per card. And this actually is a composite of several things. And it is the standard, professional standard time required to provide a specific HIV intervention. It is a composite of the number of people in each of the disease categories requiring that particular intervention, and the frequency they need that service in a particular year. So I might say a time resource required by itself is a long calculation in the background, and we end up with the time resource by cadre, by county that is required. And then we received data on how many people in the different cadre are currently employed in different counties and how much time they work to actually quantify the health time resource that's available. And these differences then gave us the unmet needs. And at the moment, what will be presented are just averages, but we are aware that these have variations. In terms of our plan, we'll include this uncertainty later with statistical distributions. So my colleague George will just present some of the results we've had at this point.
So for the demonstration, okay, so is it running?
Close and open again. Just close and open the app again.
No, no. Okay. So for the demonstration, here it is.
Maybe. Oh, hang on. Where did it go? Oh, sorry about this. Yeah, we can see it. I promise, I can see it. It exists. OJ?
I'll listen, and can you do so? Just display what's going on the screen. You've got extend currently.
Should I put it?
Yeah.
Oh, yeah, that's it. If we go up to
Yeah.
the top, make this smaller.
Yeah.
Then is it over here? You see it? Is he coming?
Maybe
here?
on the other end?
No, other end?
Yeah.
Pull it
There.
Is he coming?
Yeah.
Hang on, slowly. Oh, yes. Anticipation. Oh, but now I can't. Hang on. Oh my. Oh. But can you see? Oh my gosh. Good luck, George.
So for here we have the demonstration. So we'll be looking at the HIV prevalence. So for the specific disease that we chose to work with was HIV. So and we have the indicator needed per year, and we can be able to switch between the indicators. So if we want to work with the number of workers that are present in the counties, you can be able to see it here. Because of the screen, you can't be able to see the key down there. So I guess this is more of just a technical issue. Yeah. So then when you click, because what we are aiming at is to be able to find the deficit of the workers that are per county. So if you're able to click on this is Turkana, you'll be able to see a graph down there that has now the deficit number of workers per county and also per cadre. So you'll be able to see the number of associate workers that are needed in the county, the clinical physicians needed in the county, and so on. So you can also be able to filter per cadre in order to find out how many workers, so for example, let's say an associate nurses, that are found all over Kenya, and you can be able to switch it to the different cadres, and also when you select the indicator, you can be able to see how many number of hours are available by those specific cadres. So we also have another tab called graph. So for the graph, it just basically offers a bar plot that's per county. So it's a technical issue, but you can be able to see it on your side. So yeah, so the counties are labeled on the y-axis and now shows the hours needed per year per county. So in the next tab, you can also be able to switch the indicators. So you can be able to see how many, it's the same as the map, but not in graphical format. So you can be able to see how many number of workers are available per county, and also the hours available given by the workers per county. So for more information about our project, you can also be able to get it from the dashboard. There's also the methodology offered, where the data sets that were used, the analysis that were done, and the dashboard development, and also priority model extensions. And also from our dashboard, you can also be able to find the contact information of our team. So thank you. So let me drag it.
Oh, I think
when you click.
should. Oh, we need to get there, and then I think we go. This might work. There we go.
Yes.
So I'm going to talk about the policy value for our project. So as we have demonstrated, you can see that if we have data to inform decision making, it will help the ministry in terms of efficiency resource allocation for the human resource for health. Secondly, you can see that we have demonstrated that we have issues of productivity and coverage, especially from the HIV, what we have demonstrated. You can see a county like Nairobi, when you saw the long riding graph, they have so many workers, but low productivity, which we need to address as a country so that we have equitable distribution of these health workers to the system. And thirdly, the other thing we want to do is about efficiency. When you look at right now, the county governments are grappling in terms of the human resource for health, who to employ, who not to employ, the redistribution, because every health worker wants to work in the urban center. They don't want to work in the rural center. How do we motivate and retain these people to these rural and underserved areas? So with this model, it will enable us to come up with policies which are evidence-driven to enable us to have that efficiency in terms of allocation of resources for human resource for health, equitable distribution of the health workers. So it's a good project for us, and we are going to ensure that we develop it further, not for the one disease, for all the diseases, so that we can see how many health workers are needed by a county based on the population health needs and the epidemiological transitions which are existing. Thank you. Next to my colleague.
I'm going to lead us through the priority next steps. Having done the analysis and all that, and we've been able to come up with the HRH gap, then it means that our HRH projections are going to be evidence-based, also putting into consideration or with regard to potential future trends, like the global changes. Also and also putting into consideration epidemiological transitions, and also in terms of disease burden, therefore also be able to know how that will have effect on our HRH supply and demand. Again, we envisage to increase or to add diseases to other than HIV, which we were able to concentrate with as a result of the time limitation. And more to that, so that also we can be able to look at other diseases and be able to quantify our HRH with regard to the different disease burden. And that is why my colleague said up to 90% of every disease burden in our country, Kenya. And also looking at having established the HRH gap, therefore we will be able to estimate the resource need with regard to our health workforce, and therefore be able now to calculate or to be able to estimate the unit costs per each cadre. Thank you.
So for the maintenance plan, I'm from SEMA, so I'm going to be picking up the project and continuing with the further modifications that we need. So first of all, we'll start by making it available for everyone by hosting it on a platform, our Shiny platform also, and also working with the Ministry of Health to include all the other diseases, because right now we're only working with HIV, and to also modify the calculations. So that was our presentation.
Congratulations, you won the biscuits, I think. Questions? Who has questions for this amazing team? Dr. Lois.
Okay. Thank you. I think that's incredible. And just thinking about where you started from with not too much going on and actually have something that's a product, I think it's really incredible and very useful. I was very interested in how you actually work in burden of disease and what we know of burden of disease, and how you actually figure out that if I have a county where there's a lot of cardiovascular disease, this is the amount of human resource it would take, as opposed to if I have a county with more malnutrition, and where you'll get good burden of disease data. I mean, maybe part of the primary healthcare promoters' data may be useful in determining part of that, but how you'll get that, and just how you're determining what disease requires, or what level of burden, so to speak, requires what level of HR engagement. But I think it's fantastic. If we can do this, this is just incredible. Yeah.
Okay, it's not coming. Okay, but I can try to answer that. In terms of the disease burden, we have mapped all diseases in Kenya, which account for 99% disease burden, as the HRH working group for the ministry. So whenever we don't have a disease burden per se for a disease, we are using the WHO HIMIS data to estimate the disease burden. So currently, we have mapped all diseases, and then we did subject matter experts from all cadres to develop what we call the activity standards for every intervention in the continuum of care of diseases which we have. So we have that database in which we have developed all the activity standards, so that we know that if you are looking at HIV, for example, what is the percentage time contribution of a doctor, a nurse, a clinical officer, lab person, community health promoter. So by the end of the day, that one person, when he's receiving the 100% for this, each cadre has its own contribution, which is varied in terms of the various interventions they are doing. So we have mapped all that, and we expect to push this up to do the whole country disease burden.
Thanks, Francis.
Yeah, well done, team. I wondered, there's potentially, if you include like all the diseases that form the 99% burden, as you mentioned, that some of the workers will be supplying their skill to multiple infection areas or multiple doses. Like, how do you account for that in your framework? The second question is, obviously it's not just about the person. They need the infrastructure and they need the equipment for service readiness and quality of service. We do have a bit of that data, like on infrastructure, available equipment, and not all health facilities provide the same health services. So how do you see yourself incorporating that really critical information into your HR needs?
Okay, as I've said earlier, that in terms of incorporating the time contribution for each person for the disease, like what we have done in the health labor market analysis report, which we produced recently, what we did is that when we developed the activity standards, we have the essential package for health also data, which we are looking at each level of care. If it's a level 2, level 3, level 4, what service is offered per clinic officer, and we give the total contribution for the clinic officer in terms of that service. Then we come for a nurse, a lab person. So it's accounted per cadre to the specific disease and even to the level to develop the activity standards in terms of time.
Last question on this side.
This another one?
Oh, do you want to follow up?
Yes.
Sorry.
Okay. Yeah, that's also another thing we are trying to look at right now, because I know from the facility census which was recently done, we have a lot of data which was corrected in terms of equipment, infrastructure, and the like. But if you see the domains in terms of what came from the census report, the issues of infrastructure and equipment were well covered. You will find that the human resource for health was the one which had most of the gaps. And if you look at the current situation as it is, the investment in Kenya in the 6 building blocks of the health system strengthening, they are based more on the other pillars than the human resource for health. And you find that even the PFMR Act is trying to limit the number of healthcare workers in terms of the use of the current expenditure. So that's why we are trying to come up with a situation to demonstrate that the human resource for health is not a current expenditure, but rather another investment which should be tied when they are building a hospital, when they are buying the equipment, they should tie that one to the availability of the human resource for health to utilize this equipment and infrastructure.
In addition to what he has said briefly, and I speak from the perspective of the African Union work that we are doing, human resource for health, when we are able to demonstrate what is expected in terms of what they are supposed to do in different cadres for different disease burden, then it becomes a clarion call for everybody. We have, for example, we have employed this number of doctors in this particular facility, but they have no work to do as a result of this equipment that is missing. And therefore, it's becoming a clarion call for Africa, for all the countries, that as we invest for human resources, we also have to think of how to concurrently invest for all other pillars, because they can't work without the infrastructure being in place. So this is going to be a clarion call really for the member states and for the task forces that are involved in this. And especially when we are dealing with the issue of migration, we are also dealing with the issue of urban and rural settings, at the end of the day. So if we are sending you to the rural settings, we expect that infrastructure should be available. And I think we should have resolved that equation. Thank you.
Thank you. We have one last question, and you have a time limit of 1 minute for the answer now.
Thank you very much for the wonderful presentation. I want to believe that in the definition, we are being as broad as possible in the definition of burden of disease, considering that you gave an example of HIV just as an example, and you want to actually bring on board the rest. But then we also take cognizance of the fact that there are conditions that necessarily cannot be classified as a disease. Pregnancy, for example, I think we are all a product of pregnancy in this room. But then there's also the burden of pregnancy disease per se. So how do you include that? So I'm just hoping that you be as broad as possible and not just limit yourselves to conditions, diseases.
Yeah, I agree. Perhaps, because we'll include what you want in the end is what cadre of people that are required to offer the essential package. So when we say disease, really, it's a narrow approach. It's basically all packages in the essential, package for care, UHC, yeah.
One more round of applause for this amazing team. And now it's over to the malaria family. We have more biscuits. Keep it to 15 minutes. We have more biscuits.
Whose is this? Paula. Paula. Whose computer is this?
Whose laptop is this? Oh, mine. I need that. Sorry. Apologies.
Good afternoon. This is the malaria vaccine family. That's okay. Good afternoon. This is the malaria vaccine family. We're more than happy to be presenting our work. Some of our group members, unfortunately, are not with us. You can see all the group members. We've gone to the pain of showing all the group members so that all of you should be able to see. So we'll start with our background and just go through what we wanted to achieve through our hackathon. I'll let my colleagues start.
Okay, thank you. So on the background information, we know that malaria is a public health threat, especially in sub-Saharan Africa and particularly in Kenya. And statistics have shown that 70% of the population in Kenya are at risk of malaria. And the studies further show that 6.7 million cases have been reported with 4,000 deaths, which are recorded annually. So there has been some interventions by the government to reduce the disease burden of malaria. Some of the interventions are IRS. We have LLINs, as well as the case management and the IPT piece. But still, there is a huge problem in terms of the disease burden. So in 2019, there was an introduction of the malaria vaccine. And basically, it was a pilot program in the lake endemic zones. So these are the 8 counties in the lake region of part of Kenya, and this includes Busia, Kakamega, Bungoma, Vihiga, Kisumu, Siaya, Homa Bay, and Migori. So in malaria vaccination, there are normally 4 doses. So from the report, it has shown that there is relatively high for the vaccines coverage for the first few doses of that relatively high the overall malaria vaccine coverage in Kenya is relatively high for the first few doses of the first dose. And this coverage keeps on decreasing as the number of doses increases to up to 4. And statistics indicate that there's significantly drop in the subsequent doses, up to 24% coverage for those children who receive the vaccine to the full dose. So our challenge, our hackathon challenge is to determine the vaccine coverage as well as offer policy interventions. So I welcome the next presenter, who is Geoffrey, to give more information about the background information. Thank you.
Thank you, Augustine. So based on this, what we noticed was a challenge in terms of the dosage, where the first dosage coverage is quite high, and then that drops significantly to about 24% at the fourth dose. The current vaccine that's being implemented in Kenya is the RTSS malaria vaccine. This here is just to give you a snapshot of what is the efficacy. This is based on modeling estimates that came out of Imperial and Swiss TPH teams. And so we wanted to link this efficacy outputs to what would be the impact at the country level based on the current coverage estimates. Just a background again in terms of the country. Where does the country want to go in terms of malaria? The Kenya Malaria Strategic Plan for the 2023-2027 cycle has just been launched. The country is aiming to, reduce the incidence by 80% and deaths by about 90% by the end of the current cycle of the strategic plan. And we now have a new objective where we want to interrupt indigenous malaria transmission in about 4 counties that have been selected for what we're calling malaria elimination. This is just a classification, the current classification of the country in terms of the risk profile, which areas are at risk of malaria. This is based on a non-modeling approach where they used the PCA, or the Principal Component Analysis, through an open source platform called Jamovi, and incorporated incidence data. They incorporated temperature and a few other indicators to arrive at this classification of 6 areas, where you're seeing it goes all the way from no transmission to very high burden transmission areas. And then in terms of the vaccine implementing counties, so when we look at the vaccine implementing counties, this just shows you what are the prevalent estimates for these counties based on the latest Kenya Malaria Indicator Survey that is in 2020. And it goes all the way from, I think, 9% to about 28 point something for Busia. This was just to show where we are in terms of malaria prevalence. So the team in itself, what we wanted to achieve in terms of the hackathon is we wanted to look at the vaccine coverage currently, because the country has now implemented the vaccine at all the sub-counties within the Lake Endemic region, the 54 sub-counties. So we wanted to look at what are the current coverage estimates, and then be able to link those estimates to impact and see what has been the impact for the malaria vaccine at the current dosage levels, and look then to see if we are to increase the dosage level, that is dose 4, to the 80% that is recommended by WHO. What do we, what's the impact for the country? And that is what we wanted, to be able to quantify what is the additional cases that would be averted by, increasing dosage 4 coverage, similar to what we have with dose 3 coverage at the moment. Our work plan then involved us getting data, vaccine data from the routine data sources, which is DHIS2, for all the vaccine dosages from dose 1 all the way to dose 3. And then what we wanted is to visualize be able to visualize the prevalence at the sub-county level within a dashboard, then link these, estimates for impact for the RTSS to the prevalence, and then see, what's the impact at the subnational level. What would be the impact at the transmission, risk transmission levels, and then estimate the level of, increasing the dosages. Our final thing was to try and map this and then, put it into a visual output, which is a dashboard to show this, to be able to show this output. That's a work in progress. We'll show you what we've come up, but it is something that we aim to improve and, have a better outlook of the dashboard as we continue. I'll now ask my colleague to just come and now present how we arrived at the cases averted and what the numbers in terms of findings.
Thank you, Githinji. These are what we found. So I think just to go back, in this work plan, so some of the data that we got, we didn't really build a model, but we used existing models to estimate the impact of the vaccine. So we used the Open Malaria model and the Imperial College model, and used the estimated vaccine impact, and estimated the vaccine impact in Kenya with the target population for each of the sub-counties that we got from KHIS. So we used that to calculate the cases averted for dose 3, which for the country overall will be 63,000 cases, and for dose 4 will be 65,000 cases. So an incremental benefit of an extra dose of just about less than 2,000. And then deaths averted would be 330, and for dose 3, and for dose 4 is 346. So these are estimates over 15 years time horizon, which was used in the models that we were looking at. And for these estimates, excuse me, for these estimates, we looked at the current coverage, and that's why you can see like the incremental benefit of dose 4 isn't really significant, because our dose 4 coverage is really low, just below 30%. We further broke that down, looking at the high burden transmission areas and very high burden areas according to the new classification. And then those are the numbers that we're looking at. So we went ahead and compared if we were to, for example, get the dose 4 coverage to the current dose 3 coverage, which is fairly good. For most sub-counties, it's either over 80% or just about at 80%. So that's what is approaching the WHO target for subnational level target coverage for vaccines. So we designed this map to just show the areas where we'd get the highest impact. So the darker the color, the more the impact. It means dose 4 coverage is really low for these areas, and with the target population, if we put more effort, I think this is a sub-county in Busia. I don't know if it's Bumula, but we should be able to know which sub-county it is. So for the darker colored sub-counties, if we put in strategies to increase dose vaccine dose coverage for dose 4 to the dose 3 coverage levels, then we'll achieve the highest impact in those sub-counties. And then for additional malaria deaths that will be averted by improving dose 4 coverage as well. So we also calculated what the estimates for additional cases that would be averted with improvement in dosage, and the areas where we will actually achieve the highest impact. So if we were to have limited resources and we wanted to narrow into the areas where we'll achieve the highest impact, then these sub-counties would be the ones that we would actually focus on. So So I think this information and the analysis is on a dashboard. So before we go to the next steps, I don't know if you want to show the dashboard at the end or after. Okay. Let's finish and then you do the dashboard.
So, okay. Maybe what we can do is we will just speak to what next, and then we'll let our policy, the person who was also representing a policy, talk about maybe what the impact of this is. We aim to do a little bit more in terms of exploring more scenarios, as we've said, in terms of improving coverage, looking at what the case is. But we also want to link this to a cost-effective analysis, because from the government perspective, the main question is, how much does that save me? And we would want to link this to a cost-effective analysis in terms of the cases that would be averted by increasing the dosage coverage. We hope that maybe we can come up with a policy paper. We hope to present this in some conference, and we hope to also write a manuscript out of this. Hopefully this work then moving forward will be led by myself and Tabitha, and in contact with the other team members. Thank you.
Asante. Okay, asante. So as a policymaker, I want to make up now, want to cover it now, want to cover for full doses of the coverage. So we want to scale up for RTS. I want to cover RTS in the endemic regions, the ones who are polluted with the first that we started with the vaccine coverage. So, and we have with some strengthening now with the community health workers, so that we cover the full dose. Also, we have vector control measures of using ATNS and IRS. And also, we have some challenges as a policymakers now, improving now the full coverage of the vaccine. Like you have seen even now, with the introduction part, we have seen with the coverage now, as just with the first dose, it was now like 7%. It was very high, and the last dose, it just went down to 24%. So we want to cover for that, so that that challenge has to cover all the thing now. Also, increasing of the full dose, and this other thing that we want to prioritize, it is now with the vaccine strategy. And lastly, we let me just conducting with cost effectiveness of the vaccine, and that's what we conclude for.
I'll just ask for a minute. This is not so the sorry. This is gonna show.
I think you've already got it open in the browser tab, maybe.
No.
How do they process first? Yeah. Yeah, if you stop the process, yeah. And then yeah, it should work. There you go. It's just taking time to close it.
So the dashboard in itself is really work in progress. Ideally, what we want to show is be able to show the country risk profile, and then the vaccine implementing counties profile, the prevalence profiles, and then be able to show a map that is interactive for the different outcomes, which is the cases averted, and things like that, and then a few other of the outcomes that we were looking at. So this is really, I'd say, work in progress. We hope to finalize on this as we continue on from here. So the dashboard will have a better outlook than this, but ideally what we're going to do is show what's the current malaria burden classification, what the prevalence estimates are for the, the like endemic counties that are the ones who are implementing the vaccine, and then be able to show what the vaccine impact would be in terms of the indicators that we have calculated. So like for deaths averted, we should be able to have an interactive map that will then show the different areas and the different counties. And so someone can zoom in and be able to look at their sub-county and see, what's the added value in terms of cases averted per area and per region through an interactive platform. So this is going to be improved moving forward. This is going to at least look a little bit better after some house cleaning. But this is the vision of the group. Thank you very much, and thank you for the minutes that was added.
Any questions? Yep. I will put a timer on 5 minutes. I know you have questions. Sorry.
Good morning, everyone. Thank you very much for Team Malaria for the presentation. Yeah, thank you very much, Team Malaria, for the presentation and for the data. I think I like what is coming out in terms of the impact of maybe the kind of interventions that are being put in place by the government. My question is, I'm wondering how this translates to the implementers and the users downstream. It's very good information for policymakers and decision makers to see disease burden, but translation of improvement in coverage for those 3, those 4, is mainly on uptake and people on the ground. How do we translate this information, impactful information or inspirational information of diseases averted, which is very, very important, downstream? And how does the health worker who's running their clinic on a daily basis get to click something and see from their dashboards that this is what I need to do to be able to improve the profile of malaria uptake in our country? Thank you.
Maybe I'll answer and my team members can add. As I said, what we envision is once we have been able to show what is the numbers in terms of cases that can be averted by increasing this dosage, we want to link this then to the cost in terms of if you were to remain at where you are and if you were to improve to this level, these are the number of cases that you would be able to avert. This is the cost that would be, saved by you being able to, improve this. In terms of, translating this to the lower levels then, it would be nice to look, what we envision then is it would be nice to be able to give a visual presentation of, in terms of current coverages and the impact that those coverages are currently probably showing, and what would be the improved cover, what would be the expected, outcomes in terms of improved coverages at those subnational levels. So the map would show at the sub-county level. This then can, this can show which counties would have the highest impact, as my colleague was saying, which sub-counties or counties would have the highest impact by improving this dose 4 coverage. And that would then, be used by the healthcare workers in terms of their outreaches, in terms of improving the, vaccine uptake, in terms of coming up with messages for the community, in terms of social behavior change and acceptance, and more of that.
I have a sort of related question. What are the reasons for the poor coverage? Because if the intervention would be an increase in the dose, which I'm not sure if the drug is designed for that increased dose, but even before getting to that intervention, what are the reasons that there's poor coverage?
I don't think we can speak to that as it is at the moment. I would say that's something that would need a little bit of a community survey to do an analytical outlook on it, be able to see what's the reason. As we said, you can see the first dosages are quite very high, and then that drops very significantly to about 28 by the 4th dosage. The dosing itself is a recommended dosaging guideline by WHO. So a full dosing recommendation is 4 doses at the different intervals. But what we're noticing for the Kenyan vaccination exercise is that the fourth dose has very little, is targeting very little of the eligible population rather than compared to the first dose. So we would want, I mean, and there is, shown benefit of doing a complete 4 dose, as we've shown with more cases that would be averted. So, I mean, you can see even when, because of this very small coverage that we're doing for dose 4, we only have adding additional cases averted of about 2,000. If that coverage were to go up high, you'd see more cases that would be averted.
This is the last question, I think, if unless anyone else.
Can my colleague just add something and then
certainly.
finalize?
Just a quick one. So for the malaria vaccine, because it has 4 doses given at different intervals, the last dose is given at about 2 years of the child's life. Usually, the previous visits for immunization for children, for vaccination, used to be up to just about 1 year. So that's an additional visit which probably parents are struggling with. It wasn't an existent visit to the facility. So that could be one of the reasons that then parents need to be encouraged that, beyond 1 year, then there's an additional vaccine that you need to bring your child for.
Thank you for the presentation. So a quick one is probably because we know malaria prevention and control is integrating of many interventions. It would be nice to, as you say, cases averted, you also point out what the other interventions are averting, because that is important for decision making. Number 2, when you look at the data moving from dose 3 to dose 4, I think you are adding 2,000 cases. I may not have seen it clearly. So the question is that warranted given the resources you need to pump in, or do I distribute nets? These are some of the decisions that you need to be made. So you need to produce that. You need to provide that information together. Thank you.
So maybe just to highlight, one, on the cases averted, the 2,000 is at the current levels. So we are yet to do, we'll show the calculation, moving forward when we do further analysis, in terms of what would be the numbers if that coverage is to be increased to 80. And can that justify then the investment into trying to improve the coverage? So the 2,000 additional cases that are averted by dose 4 is only for the current coverage, which is like 20-something%. So if you were to up that to 80%, then you're definitely going to see more numbers. Then this calculation is linked to interventions for the other interventions. So this is what the vaccine in itself is, contributing in terms of cases averted and deaths averted, based on the current intervention. So we are assuming for the other interventions, the interventions are stagnant, as they are at the moment. So like for nets coverage, for IRS, so we're not varying the other interventions. We're only varying the vaccine and assuming that the impact. So one of the other things we wanted to look at is, compare pre-2018, prior to the introduction of the vaccine, and then after the vaccine, and seeing a time series analysis of maybe where the vaccine impact. That's one of the other, further analysis that we'll do, just to link the cases averted that would be directly linked to the malaria vaccine. And the reason why we didn't actually do that this time is because the KHIS data is cut off at 2022. Is it? Yeah. So we were not able to get data from the previous years. If we were to, then it would be something that we'd definitely be able. Malaria program should be able to provide the data because they have backup sources, and that's something we'll definitely look to quantify specifically for the vaccine.
Thank you so much, Malaria Family. One last round of applause for the team, please. Sorry, Tommy, did you want to ask another question? No. Okay. Co-chain Family. We have more biscuits. 15 minutes, please.
Where's the cable? Which cable? Ah, okay. Okay, good afternoon, everyone. So my team and I, my team included Fatia Hamumi, Preston Osoro, Bonventure Mayo, Emmanuel Kibet, Peter Waweru, Stephanie Kamunye, and myself. And so the challenge we were presented with is that the National Vaccines and Immunization program are having a challenge in visualizing and using data for capacities at the facility levels. And so what we were working on was to create a centralized, up-to-date system on capacities at the facilities level. One of the biggest challenges they've been facing is getting up-to-date information on capacities at each facilities. So that's the challenge we are working on solving. And the proposed workflow. So from the individual facilities, they will have to submit this data into the KHIS system. So for our one-time entry, we'll need the make, model, serial number, year of manufacture, year of installation, and the status of the equipment at each facility. So this information is what we'll use to compute the capacity, available capacity, utilized capacity, and the unutilized functional capacity at each facility. And so for a monthly update on the condition and status of the equipment, this is the information that they will need to submit monthly. Going forward, we are proposing that we use automatic fridge tags that send information on the condition and status of the equipment directly into the system, rather than having the health workers input this information manually each month. So I'll invite one of my teammates to explain the technical bit on the website.
Good afternoon, everyone. My name is Preston. From the problem statement we were presented with, the problem statement in itself suggested the idea of developing a tool that would effectively monitor and manage cold chain facilities, with the object being to ensure optimal utilization and performance. And in a nutshell, this spoke more to having a system as compared to what myself and Kibet, especially on the technical bench, we've had it being thrown around quite often, and that's all about the tool on R. It's something that we wrapped our minds around, trying to figure out how we are going to solve this problem, especially with respect to developing a tool that's going to help us to effectively monitor and manage these cold chain facilities. For a moment we were stumbled, but then again we came to a conclusion whereby we didn't quite consider R as a tool that's going to help us develop this system, because from the problem statement itself, it's clearly and relatively easy to see that we need a tool, and this tool in itself is an interactive user interface that's a dashboard in a sense, but in this category we sought to use React. We built a system that's basically on the front end and the back end. So we had our front end. Our front end was purely built on React and some bit of its framework. That's the JavaScript framework, which is React, and then we employed TypeScript. On the back end bit, we'd thought to consider Python, but it's something that we may have to consider it at some point in the future, especially if given the time to develop the application further. So we hosted our data after it was cleaned. We wrote a script that converted that data into a JSON file. After that, we deployed that data to Cloudflare, where we were able to have it hosted there on a free tier. And then we worked on the front-end application, where I think it would be convenient for us to have a look at it. This is the website that we have. It's basically an application, because that's what our problem statement sort of dictated. So I'll introduce my brother to take us through this. There's a lot of AP. Hoping that it's clear. So I'll introduce Philip to take us through it, for the simple reason that I'm not most familiar with this jargon around epidemiology. He'll take us through the user journey.
So this is the dashboard we came up with, and you are able to select your county over here. So for our case study, we were using Turkana Central Sub-County for demonstration purposes. So you select your county, then select the sub-county you're interested in. Then you can see the total number of facilities, total capacity available at that administrative level, and the total unutilized functional capacity. So the importance of total unutilized capacity is, in cases where we need to send more vaccines to these facilities, we are able to know how much available capacity is there. Because for the cold chain equipment, they usually have routine antigens. So we are going to, that's what we are calling, okay, let me show you. Let's select a facility, let's say Kalokol. The map will zoom in into the facility on the map. Then you can click on the marker. Sorry. So you can zoom into the facility, and the facility marker will provide you with this information. So that's information on total available functional capacity at that facility, the required capacity to store the routine antigens, and also the unutilized capacity that can be used for various storages of maybe extra vaccines that need to be supplied to this facility, or in cases of outbreaks, when you need to send a particular vaccine to be stored at these facilities, you'll be able to know how much capacity is available at these facilities. We also have the population of children under 1, and also for which is used for to inform decision on vaccines for children, e.g. BCG, and 10-year-old girls population, which is used to inform decision on HPV vaccines. So at the top, we have another tab for analytics, where we are able to visualize the capacity information. So from these graphs, you can see, so the purple lines indicate the required capacity, and the green lines indicate the total capacity. So for example, for a facility like this one, it's standing out, it's Lodwar County Referral Hospital. You can see that the required capacity is way higher than what they have available. So they have a shortage of capacity to be able to store routine antigens for their target catchment population. But when you look at a facility like this one, they have more capacity available to them than what they actually need. So this information can inform reallocation of equipment from areas that don't necessarily require to have that much storage. They can be sent to the facilities that are in actual need of this equipment. So from this dashboard, you can be able to inform decision in equipment distribution, reallocation, and utilization. So we'll be able to add a function where you can see on the map, you can be able to see the functional condition and status of the equipment at each facility. So go back to the slide, yeah.
Oh my God. I have no idea. Okay, back to this side.
Thank you. So I'm going to invite our decision makers to tell us more on policy values.
Good afternoon, everyone. I think that was wonderful work by our team. And it's not very scientific, so it's easy to turn your heads around during this time, especially being the last group. We have to kind of impress everybody. Given that, having said that, so as I speak to this slide and also a quick background to what we are doing, there are a number of systems and equipment that are attempting to answer this gap that is there. We know that vaccines are actually hosted or housed in refrigerators or cold chain equipment, meaning recommended temperatures. And most of the time, there's huge investments within the ministry and outside the ministry by our partners to kind of strengthen this cold chain capacity and functionality. And most of the time at national level, we do not have visibility. Like he says, there are things that you record as a one-time, where this equipment has gone, where it's been distributed, the model, the make, and how it performs gives us an idea to the pre-qualified. There are different vendors of this vaccine, and we need to know how each is functioning to be able to make better decisions. So most of the time you get counties telling you that they need more and more. And of course, at national levels, we are continuously introducing new vaccines. We're all aware that COVID came, and nobody knew that every individual, including the aged, would use the COVID vaccine. So that really expanded the need for the country and for the globe in general. So having that, the information on the numbers and the functionality, given the dynamics on the ground, that these are just like any other implementing center, these things are dynamic, that would break down, that would be reallocated. So we needed a platform to show that dynamicity on the go and the visibility, because we could have what we've given, but the status could be very different as we speak at any one point. So this speaks to equipment distribution and utilization, reallocation of equipment, as they've pronounced, any additional introductions within the country, any new vaccine, including the Mpox that is almost coming up, will be able to be served by this. And we can talk more around this, but I think we want to have the biscuits, so we can move on.
So on next steps, we are looking to integrate fridge tags that automatically send alarms on temperature monitoring of equipment, so that we can know as soon as the equipment is faulty, we are able to get that information on the website. So as you had seen, the map had blue and red tags. So you can be able, just looking at the map, you can be able to tell the condition of equipment at these facilities. And also we are looking to integrate equipment specification and conditions to the tags, so that when you select your facility, you can be able to get this information. And also we'll be including a platform for maintenance communication. Our health policymaker had advised on this, so that you can be able, once the fridge tag sends the information about the faulty equipment, it can be able to advise on the repairs needed and the rectification at that facility for that specific equipment. And also we are looking to integrate digital forms to collect information at facility level directly into KHIS. So as it is right now, each facility submits a physical form to the sub-county level, where someone has to input this information directly to KHIS, but that's not the most efficient way to do it. So we are looking to have digital forms that can be filled remotely from each facility. They don't have to submit a form at the sub-county level. So each month, they'll be, as they submit their monthly reports to KHIS, they'll also include the information on the cold chain equipment. And also we are looking to integrate a way to get automatic report generation, so that the decision makers can have reports from the data to inform their decision making. Maintenance plan. In our group, we have Stephanie and I from SEMA. We will be carrying the work forward, also with input from the MOH technical team and my fellow team members. Thank you.
Thank you so much. I think they want the biscuits, yes.
Maybe just to wrap up before the questions are welcomed. So a special thanks to the organizers of the event, the policymakers, hackers, who have made this event successful. And most importantly, the special team, amazing team to be. I've learned actually a lot, not just technically, but also the way in which technology can be leveraged to, bridging the gap, especially in the health sector. The hackathon has been eye-opening, and yeah, I've learned a lot. And actually, we see an immense potential in scaling this solution forward. And we believe that moving forward, it's something that is going to bridge the gaps that are being seen in the health monitoring systems. Thank you.
Thank you so much. Does anyone have questions? Yeah, please stay. So please stay. Yeah.
Just one question regarding, you've talked about the cold storage, but I assume that is just one component of how this whole service would function. Like, have you thought about other tangential components of which would support the cold storage facilities? For example, backup power, electricity reliability, internet connectivity, for them to feed back information. Could you talk a little bit about how those could be integrated and what the set of items would be needed to make sure this is a comprehensive system?
Maybe allow me to take up that. We realize that what just mentioning constitutes what we call a robust cold chain system. For us, and the limited time that we had, we focused on actually just basically having an inventory. But of course, in the next steps, as you mentioned about ensuring that actually the vaccines are potent, then we're talking about issues to do with power. And of course, power, we're talking about equipment that are connected to the national grid and those that are actually solar powered. So of course, with that, we have the alarm system. Broadly, what you mentioned about the free tags and how we can actually be able to get this information real time, like click of a button. So it's a wide spectrum of what we need to input, but we just laid the foundation of what we need to work on as next steps.
And thank you for thinking about that. I think there's a part on the next step that deals with the equipment specificity, and some of which is the sources of power. And we know that equipment nowadays can be operated by grid or solar, or a hybrid of both, whether there's battery and whether there's voltage stabilizers attached to it, and if they are, that should regulate the equipment not to actually break down. So that's a whole platform on specificity. Thank you.
Any other remarks or questions? Yep.
So thank you for the very good work. I saw one of the indicators was the population of under 1 year. And I wondered where that information comes from. I think it's also connected a little bit to like the quality group. We have, and I'm looking at Dr. Okunga now, we have another department called CVRS that is interested in registering births and deaths. And I'm wondering whether at some point the denominator for what we use in our analysis here should also be fed from CVRS, or at least the estimates that are made every year about fertility rates and all.
So the population information, we got it from NVIP, the National Vaccines and Immunization Program. So they provided the catchment population. So that's the catchment population that are targeted in Turkana Central Sub-County for the immunization of. So the under ones is for the BCGs, and the 10-year-old girls is for the HPV vaccine.
We have to work with the Ministry of Planning to get these denominators. And perhaps that was just an error because we are used to talking about under ones. Malaria just talked about it. We are now beyond, it's called life course vaccines. There's under 2 years, and then there's the one that takes life course, the adult and adolescent and the geriatrics and everybody else who uses any other vaccine. Yeah, so that's where the information comes from. And it needs to be validated with what's on the ground, largely informed by census, and then projected or modeled for the next years. I hope that answers your question.
Yep.
Okay, so even with that data that came through, Cosmas had done some work on estimating number of children who are under 1 in each health facility based on previous coverage of vaccines. So based on previous vaccines administered and estimated coverage within that area. And what was interesting is Cosmas's numbers didn't differ too much from the MOH one. So like maybe Cosmas is saying 78, MOH is saying 75. So we didn't see too much of a difference.
I think, no, John. Yeah. Oh, okay, let me start here. Sorry.
Thanks. I noticed Professor Thumbi was trying to nab me somewhere. But I think the issue of these populations and census, we all know the challenges that come with them. The official estimates, of course, are the census. But we have an opportunity to actually get fairly good data right now with the community health system and the deployment of the community health promoters, the ICHIS system. So we'll be able to get fairly real-time data. I'm sure as we juxtapose those data sets, we'll be able to also see why we need to also relook at some of the coverages we have and all that. CRVS is part of this whole process. I think they'll be looking forward to the ICHIS data also. It must be very important.
Thank you. John, do you want to add?
Thank you. Mostly a comment rather than a question. First, there's a lot that goes into deciding what functional cold chain capacity remains, which might include how even the vaccines are packaged, all that information. So it's very critical for your team, at least on that platform, to include your methodology so that we're able to appreciate and criticize it and improve. Secondly, at the moment, it's able to help with looking at the current snapshot of the cold chain and what's available. Do you envisage a situation where it might be used actually for projecting a year or two now for planning purposes with the ministry? This is what you might need according to how perhaps the demographics are changing, or whether there are any plans. For example, if there's work to try and increase vaccine uptake, for example, in the malaria case, what would that mean for the cold chain if such thoughts can be built into the system?
Okay, to answer you, once we have a conclusive system and we've collected the data that we need, we've identified the data that we need, then collected it, we are able to understand now what can we do with the information we have, what is possible, what is not. So that's where the predictions and further analysis on this data can be done. Yes.
Okay, one more round of applause, please, for this family. And I think we have the demonstration now of the animal surveillance team.
As we set up, can I just say a huge thank you for your patience, giving us some extra time. It's super unfortunate that the biggest bottleneck we had this week was in front of everyone rather than just at our table. But I think huge congrats to Ryan and to Anne for working so hard under pressure to solve this. I think shows really excellent resilience, which is a really important skill to have. So extra round of applause for Anne and Ryan for fixing this morning.
We can confirm that we've all had demonstration troubles in the past at conferences, and I think we all have a story to share.
Hands up if you had.
What's the click?
So most people.
Okay, so Purity, do you want to do a quick bring us back and then
I'll bring us back quickly to what our challenge was. So currently, Hubs as a tool to collect data and kind of analyze data at the directorate. And unfortunately, we do not have a database from which the data from CABS is stored. And the data right now there is fragmented, inconsistent, and sometimes even incomplete. That makes it quite difficult to track disease trends effectively, and thereafter, have actionable insights on which informed decisions can be made. So that was the challenge for the week, and let's see how we were able to come up with a solution.
Hi, good afternoon. I'm sorry. So I think most of the work that we did this week was more into database creation and data cleaning, because currently the way the CABS system is working is that when the vets when the vets are collecting the data, they store it in the CABS system, but then it doesn't allow them to clean, they have to do manual cleaning of data. So most of the work went into cleaning that data and then storing it and hosting it in the database. So the visualization I'm going to show you will actually need a lot of other visualizations, more because the data we're using was dummy data. So here goes. So on the landing page, Purity, who is the policymaker, they wanted to see automatic updates about vets, vet data worldwide and also locally. So currently we only have the worldwide data as the events are occurring. However, for the local, Purity said that they're going to make a team that will be producing local news on animal surveillance. So for the local tab, there's nothing there for now. And then for the visualization, so I wanted to see the national summary or aggregate of different animal diseases. So we are going to select by government because all their data is coming from GeoK sources, okay? So another part of the work was to link the different data sets from different sources. So we have one sources from the GeoK and other sources from laboratories and laboratories. So currently we're just working with the ones from CAB system. So the map is interactive, I think, yes. So if you can filter by disease name and just to get a summary of how different diseases or different counties are in terms of the number of risk of diseases. So right now we're using foot and mouth, and we say Marsabit is, so the darker the shade, the higher the risk of that disease. So a county like Tana River, we see that has a higher risk of getting foot and mouth disease, according to the DEMI data that we're working on. So also you can filter by county, just to see individual counties and how their sub-counties are looking in terms of disease. And for the Busia, we see TESO, and you can play around with it. But then I think there's room to improve the dashboard. So other than that, the policymakers also wanted to view particular diseases and their statistics across. So this is still work in progress, however. So the number of priority diseases out of the list of many diseases that are given. So we've managed to do anthrax and brucellosis, but then we'll keep adding as more data comes in. So what we can see here is the number of animals with risk of getting anthrax. And here we've aggregated, so they give us key indicators of what they wanted to see how anthrax is performing. So the first one was the number of risk, number of death, number of vaccinated, and the number of affected, as well as the humans who are affected by that disease, which is zoonosis I took on. So with that, we see the number of risk aggregated, and then on this other graph, we're able to see which countries are being affected more by anthrax. So Garissa tops. For brucellosis, the same thing, basically. But this part, we're thinking of putting maps, Kenyan maps, that will further show in-depth analysis when we get more data coming in. So we hope to improve this as time goes by. So for the next steps, the way currently we're fetching the data, so VDS, which is the vet services, they're creating a new iteration of CABs. So with that, we want to read directly to it, other than downloading the data and then cleaning it. So we want to have a full end pipeline of from CABs to cleaning to database seamlessly. So with the new one, we're working with WSU to create APIs for the new CABs system that will link directly to the CAB system and to the database that we've created, so that the data, as it's being put on, as it's being fed in the new CABs, will automatically update our dashboards. Because currently, we have to load the new data that has been put on and then visualize them. But we want that process to be seamless, since that was the initial problem that was put to us. So when the CABs, the other version is created by WSU, and then we get the endpoints, we're going to have a seamless. So as data comes in, the dashboards update automatically. Thank you.
As the policymakers, we appreciate the work that has been done, and we are quite positive that this will support our mandate, which is basically safeguarding animal and human health and increasing animal productivity, and ensuring as well that we have safe and high quality animal products. So previously, as I had mentioned, dealing with data and just thinking about data with regards to surveillance was quite a tedious process and did not inform much. But we hope from now going forward, it's going to be automated, starting from cleaning all the way to analysis, and be more informative on the decisions that we make. So the three main things that as policymakers we hope to achieve once we implement this tool is efficiency, equity, and sustainability. Efficiency in automating our systems with regards to data that eliminates, the bottlenecks in our surveillance process, so that we have like near real-time insights for faster and more informed decision making, as well as response to some of the events that happen in animal health. For equity, the data that we get, we hope to have data from even remote areas and areas that are underserved, so that we have policies that reflect the realities of even the communities at large. For sustainability, we want to hope that reducing our reliance on manual processes will build a foundation, for long-term surveillance improvements, and making this scalable and adaptable, so that, when we have newer challenges emerging in future, we can still be able to use this tool in future. So I regard this not just as a technical innovation, but also a strategic asset for us, that it will give us evidence from which we can be able to prioritize interventions, do budget allocations, as well as, monitor the impact of the policies that we make. So this is just the beginning, and I believe not only for this tool, but for all the rest that have been developed, the real value will come in how we implement this in our day-to-day activities. Yes, so going forward, as we had earlier indicated our interests in a marriage with SEMA, like MOH has, we have tested what potentially it could be, and we hope that this is the discussion we can have going forward. Thanks.
For the maintenance bit, I think I've touched across while I was presenting, but just to give a summary of what we intend to do. So the first thing that they requested was efficiency to remove the manual cleaning. So that part I can say we've dealt with because the system, the pipelines are already working and the data is being cleaned directly from the Excel sheets that we're downloading to the database. So once WSU finishes up with CABS version 2, then we hope that we'll have APIs to read directly into that. So we'll just edit a bit of code up there, and then we'll have seamless cleaning from CABS to the database. Then the next thing will be to have more visualizations as more data comes in, because the dashboard right now, it needs more visualization to give a better picture, right, in terms of maps, and then that is what we'll work forward to. So in summer maintenance, it's me and Ryan, so we hope to finish this work and that you'll be happy with the output. Okay, thank you.
So much. This was amazing. The vet in the room. Do you want to?
So first of all, I wanted to congratulate you because I know this question came on Friday, and here you are the next Friday with an amazing tool already. What I would encourage you is to think like we have a blank page. Like we don't have a system that thinks through numbers of animals. There are different species, it's not just one like humans. You have almost 7 important domestic animals. And you need to think about like what are the populations of cattle in the smallest implementation unit, which might be a sub-county. Then we need to think about like mortality data. I know CABS might have a bit of that, and has also a lot of morbidity data, and morbidity is numerous infections. And then the other critical thing is like when we take our oath is to protect public health, but also to provide good food. So there's the economics and the productivity of animals. So in a way, if you could also get information about the productivity, where is the milk coming from, where is the meat coming from, what are the prices which you can get from KNBS, and they conduct very good surveys. You could have a very rich data set that when you make eventually like a model about the big vaccination campaigns that are going to be happening, what is the likely impact of that on animal numbers, but also productivity and the economics. And therein, I think you'll have the tool you require to ask for more investments in the vet sector. But well done.
Thank you. Any other comments in the room? Zoom? Oh, how do I? No, but for you, how can they connect? Okay. Please ask. Yeah?
Can you hear me well? Okay, perfect. So, trying to figure out if I'm audible. Okay, so yeah, I think first things first is to really appreciate Sema and team for putting this together. As Tumbi has said, this came up the other day in a meeting, I think on Friday, and it's amazing that in a week we can get here. So yeah, a lot of appreciation to the team from Sema putting this together. I think as Tumbi, we have a blank check to basically really make a good system. That's the pledge we got from the DVS. We are very willing to experiment and improve the system. So not just thinking in the traditional data presentation, but we were given the go ahead to sort of be as innovative as possible. So that's the pledge we got. And one of the issues we have, like right now, I know you have, there's this livestock vaccination debate. There's a lot of need for data visualization because you are being asked, what's the justification, for example, for vaccine, for distributing vaccines to certain areas and not others. And the policymakers we are speaking to right now at the level, they don't want numbers. They want to see figures and maps. So I was very impressed to see the whole visualization module in the presentation bit. So basically, I think it's a pledge from us to work with SEMA through and through, give you like full access. And we hope in the next 3 or so months, we'll really see a product that we can present at the highest levels and we can always say, we did this with SEMA and make an actual impact. In the policy, last comment, in the policy slides, I know Purity talked about the importance of health. Livestock data is useful. Now is
Sorry, we can't hear you. Is it our connection? His.
partners, these agreements we have with the EU and all, want to see our data.
Thank you. I hope this is allowed. I wanted to ask Arani, do you think there could be any value in some predictive modelling with the data that you've seen from CABS?
Okay, thank you. Yeah, I think it's a possibility. Yeah.
Great.
Do you want to elaborate which model? MCMC or? Are there any more questions in the room? Yes, there is.
Thanks, and it's really not a question, and I'm part of the group, but in terms of taking the work forward, currently the work is mainly within the vet side, but ideally what you're supposed to see now is how to overlay the human cases on the same and have a One Health display of the same. And there are priority One Health diseases that we already have as a country. So I think from the zoonotic disease unit, we can support some of this work to make it more useful to the country. There are particular areas of interest in terms of what has been asked about prediction. That will also come through that, and we already have indicator diseases like the influenza viruses, which can be worked on.
Is he back online? Yes. he can speak. No? Can you hear me? It's weird.
Oh, wait, is it? I'm not sure who you were addressing. Was it me?
Yes, it's yeah. Your question earlier on the policy slide. Would you mind repeating it?
Yes, no, sorry, my connection is really bad. But I was saying, in terms of our trading, our data, one of the reasons we really need very good data and the ability to visualize our information is trading partners, our trading partners in the Middle East and some of the countries with our approach in the EU to trade in our livestock products are asking for the ability to visualize surveillance data as evidence that we are free from certain diseases. They said besides the whole public health component and animal welfare, the ability to improve our surveillance and our data analytics and visualization and predictive modeling, as we talked about risk assessment, will have a huge impact on our ability to access certain trade markets. And I think a very important point in the policy slide was to sort of expound how improving surveillance and visualization has a direct impact on our ability to trade and improving the economic status of the country. So that's what I mentioned, in case I was not clear before. Thank you.
Is there anything you want to add in response to any of the comments you heard? Otherwise, I suggest we give another big round of applause to the enemy surveillance team and their demonstration.
Maybe what I can say is that those are great feedbacks that we've received, and maybe you've given us even a better picture of how to address the problem. So in the next month, week, we'll see what we have come up with. Yeah, thank you.
Great. Gonna just wrap up by giving a short reflection presentation on the process of the hackathon, then hand it over to Dr. Lois and Dr. Tumbi. We will keep it brief because lunch is ready, I think, at 1:45.
So, I'm up here. Cool. So, everyone who was in the room, yesterday you were asked to provide feedback on the hackathon. And so overnight we have been collecting all that feedback and we've been conducting some sentiment analysis to identify some of the key themes and comments from the group, which we thought would be interesting to share as we summarize today. So firstly, I'll just go quickly through, put them all up there. So firstly, we wanted to understand what aspects you thought in the room made this hackathon an effective event. And the kind of top three themes that came out with this was having group diversity, so having both hackers and decision makers, having a clear goal, so having those challenge ideas presented up in ahead of time, and having an actual interactive environment for this week, so having a mix of both icebreakers, some debriefs, and then having that ability to interact with individuals from outside your usual working norm. We've had a few choice quotes from people who are either happy to disclose themselves or anonymous, but I think it's just really helpful to see that some of the people were really landing on the ideas of how important it was to enable everyone to hit the ground running with those challenge areas. And again, that kind of mix of backgrounds being really essential for the success of the event. Because we're always, we want to know what we can do better, we also asked what could have been improved. So everyone wanted more time. Specifically also, Lilith wondered if we could double the length of the hackathon. Yeah, I think so. Oh no, Giovanni? That wasn't me. It's in there. Okay, that's fine. Okay. Okay. Anyway, No, Lilith, you said it. It's fine. But there was a comment definitely about wanting to double the length of the hackathon, which we'd love to do. So we will seek out more funding in the future. And then also more want for a better lit environment, but also pre-event preparation as well. So whether even earlier could the challenges in the data be shared. On what aspects could help the teams collaborate effectively. So we wanted to understand what worked and again, what could be better about enabling this. And really, again, this was about having those icebreakers, but also, again, having individuals from different groups. So I think from the point at which each working group had formed, having the ability for those individuals to actually have the time to interact with each other, understand the different backgrounds and skills in their group, and definitely the family aspect. I think there were a lot of comments about the enjoyment of the families.
During the presentation, I think it was George who said, "My brother is going to present the next slide." I love that. Great. Yeah, sorry, go ahead.
We loved it. We really enjoyed how everyone felt like a family and felt very comfortable in their groups. And I think that definitely showed in the presentations. And then we also had a next section about what the participants felt were the actual merits for themselves. So what they learned and what that included. So a lot of this was around skill development. So definitely it was for a number of people their first time working collaboratively through GitHub. So lots of individuals reflected on Git and GitHub and having the ability to learn that through the medium of working on a collaborative project. But also just, again, I think having that enjoyable environment. So having the ability to kind of connect with people in a friendly, relaxed way kind of helped individuals have the opportunity to network as well. And then, because this was really focused around knowledge translation as an event, we wanted to ask what was effective for that knowledge translation. So again, clearly, some of the key things coming out were having those focus problem statements, that pre-event planning, but also I think people, again, reflected they wanted longer working time. So whether that, again, could be either upfront working time, so preparatory work, or whether that could be, again, through a longer event. We will look for more funding, don't worry. This will not be the last hackathon. And lastly, I wanted to share some milestones that were reached this week. So firstly, since I enjoyed it so much the other day, put your hands up if you think there were over 300 GitHub commits across all groups. Keep them up if you think it was more than 350. 400. Do I hear 450? Do I hear 500 in the room? Okay. Anyone 550? 542 commits across all of the working groups. And the total number of individuals who committed code was 36 unique individuals committed to code in each of the main branches in the groups, which is really impressive, especially given the different backgrounds and familiarity with GitHub prior to this event. And last one, just for me, total number of biscuits consumed, I think at least 196 biscuits based on the number of packets brought. So those are my closing reflections. And some more.
Yeah, maybe just to add to what OJ just mentioned, I think one thing that was really stood out for me is that some groups truly benefited from policymakers, decision makers staying in their group throughout the week. So I just wanted to say thank you to those individuals for sacrificing their time. Specifically, Purity, Mumbua, and Anna, very helpful comments. And I think it was at this point of where someone was just looking over their shoulder and said, oh, I prefer to be on this axis versus on that axis. And that input was very useful for the coders to improve the software, I think. But then there was also Florence who stayed in the group and I think had very valuable insights and contributions to the team. I don't think I ever spoke to this group and I was so impressed to see what you guys did and came up with. And Francis, huge thanks for coming up with this new challenge on the spot on Monday. And actually standing behind it and pitching it. And I think you got 5, 6, 7 people fully motivated to be a part of your pitch. So that's really great. Well done. Jacqueline, I think you were initially in a different group, and you were so excited about this that you moved to this family. So that's very honorable. Thank you. I think then I just wanted to point out some personal achievements that I saw, but obviously I got to know everyone better. I think Tony presented on multiple occasions very well and improved hugely. Thank you. Yeah. I think George's team surprised me personally the most because, again, I didn't have any insight, and it was very impressive to see that. Tabitha became a coder. Whether she wants to admit to it or not, I don't know. But yeah, I want to thank you all for joining this week and being open to this new idea. It was the first time we did it, and we enjoyed it very much. Thank you. Yeah, so, I mean, now thanks to Tumbi, obviously, and Lois for giving us the chance to do all of this, and Jeanette for hiding in the background. Without her, we would not have been able to set this up at all. Can I pass it over to you for some closing remarks? And we have a certificate for everyone. Please feel free to pick that up from where they are on the way to lunch. Yeah, or after lunch, as you see fit. Thank you.
Thank you very much, Paula. Jeanette, do you want to say something before we close? Jeanette, we are asking you to come and say something before we close. No, you have to say something. Come and say something brief before we close.
So it was very nice to hear that Ministry of Agriculture also wants SEMA to be a wife, where we are not exclusive. And as you can see, we are a very good wife to the Ministry of Health, and we are looking forward to be just as good a wife to the Ministry of Agriculture. Thumbi, I'll fill you in later, but it's good to be a wife. So really, when we think about SEMA and what SEMA is set out to do, this is exactly it. We are formed to support evidence-based decision-making. So when we have an opportunity like this to showcase what we are able to do, it makes us very proud. This is why we are here. This is why we exist. So thank you so much for putting in the effort. I hope we continue to impress you beyond this 1 week. We continue to impress you over the course of the year, so you see the completion of some of these things. We are very collaborative in nature, and I think the team from ICL, Camry Wellcome Trust, you've got to see that. SEMA is open doors. The more the merrier. As long as we can get to that goal, let's do it together. I believe we go further when we go together. And for my last point, I know there are people here who love photos, you know yourselves. So Vinny has been taking very good photos, and by next week you'll be given a link so that you can go and download your photos. So thank you so much for your support. Now back to Big Sis and Big Bro.
I think we knew Jeanette had something to say, but she had good stuff to say. So Fimbo will give a final closing remarks, but I think there are a few lessons that we've picked from this. One, that it shouldn't be a one-off. We have to have many, many hackathons coming. But I think the other thing is around the engagement with policymakers. I think you pointed it out very well. And Dr. Kunga, you're going to be the ambassador to get more policymakers into the room. But having policymakers ask the right questions and seeing those questions and the answers to those questions come to life is really important. So I think even as we go ahead, the issues around identifying questions early, getting people to begin to work on those questions and coming together, and within a very short time being able to offer solutions, to some of those problems and some of those questions is really critical. And I think even as we go forward, that's something that we should embrace more of and work more towards, and work closer with the policymakers and have them in the room asking the questions rather than being fed answers to questions that they're not a part of. So I think that would be really critical as we go forward. and as we think of how do we engage policymakers more. I think the other thing, and even for the policymakers in the room, is that this shouldn't be a one-off engagement, as I've said, and not just that we'll come together for another hackathon, but I think for us is to invite you to continue to engage with the team at SEMA to work towards carrying some of these things to conclusion. And there are many channels through which you can engage with SEMA on that. And we can discuss later and say, is it about maybe taking up a fellowship at SEMA to help you carry this work forward to the very end. So we're really happy to just keep this conversation going and to make sure that whatever is started here doesn't end here. Luckily, we have the brilliant young people who have said they're going to be there. Maintenance team. What did you call it? And they're going, was it maintenance team? What did they say? Maintenance team, yes, to continue to support this work so that nothing falls through the cracks and that everything really just comes to a logical conclusion. I think just the last one is something that came in, I think, as the very last team presented. And it was around having a One Health approach, which I think was, fantastic suggestion. And just that so many sectors need to work together. It's not just human health, there's animal health, there's environmental health. So there's so many other sectors that we need to engage and to continue working together really for the betterment of outcomes of our populations and our patients. So thank you all very much. Great seeing you all, and we wish you the very best. So SEMA is open door. Jeanette even dared to call us promiscuous. So please don't go away, keep coming back. Thank you all so much. Thumbi.
So thank you, Lois. What I'd like to do is ask you to clap for each of these groups. So the first, let me tell you who to clap for. The hackers and the policymakers, all of you that sat on those tables, came up with questions and tackled them within a very short time. Congratulations. And the facilitators, some of whom flew many hours from London to here, OJ, and we have one of our own here that we play paddle with. We want to congratulate the team from Imperial for finding time to come and interact with us. I hope this has sort of been very useful for you as well, and that you can keep with this collaboration. And then there are normally very silent people that make things work. Waidera and Noel behind there. And then you've got IT gurus in the name of Brian. We congratulate you. Thank you very much. And to say that we are very excited, as indicated by Jeanette and Lois, we have a mandate to improve the health of Kenyans and the health of people living on the continent through the use of data. The idea is not just to convert data into information, it's actually to convert data into information that you cannot ignore. And that's a challenge that we have got here, that once you work through your data, you get some information, Okunga must not ignore it because of the much insight that you get out of that information. So we hope that day by day we will continue growing our strength and ability to provide insights that cannot be ignored and that will influence our health and the health of the people that live on this continent and elsewhere. So no other words from me, it's just to say congratulations. I think you have got lots of certificates to take home. And lots of food as well. So, OJ, back to you, and Paula. Oh, because
so on it, what's right. No, stay. No, not biscuits, chocolates, even better. There we go. So, just kind of closing set of thanks. Firstly, this is a thank you from myself and everyone else at Imperial to SEMA as a collective. No, that's right. And just to add to that, I'm truly incredibly grateful for all of your help this week supporting this event, but all the help over the last 10 months supporting Paula here. I know it was a strange working arrangement that we set up, where Paula arrived and said, I'm here. But you have made her feel one of the family. I feel she feels really settled here, and it's been exceptional to see the warmth that she has received. And I hope now, almost a year on, this sort of working arrangement is clearly showing the benefit, as this event hopefully demonstrates today. So thank you very much for the support and the love that you've shown to Paula. And then I have one last set of thank you for the other main organizer of this room. Everyone else has got some chocolates or biscuits, which is for Paula, who, as well as organizing alongside Jeanette and all the team at SEMA this event, has just been, I'd say, my rock this weekend in advance, helping support this. And before I came over, she sent me a long list of things she would like me to sneak past immigration and tax. One of which I have here today, which is a board game she requested, which I now hope she will be able to play with her family as well. So a big thank you to Paula as well.
We have not taken a group picture yet. We've not taken a group picture yet. So before we go for lunch, let's take one group picture. Brian will, Vinny or Brian will lead the group picture, yes? Where are we doing it? Main campus, eh? Okay. Okay. Let's do it.
It's easier though for a proper group picture because the ground is flat on that side. So you end up missing people at the back.
Mm.
Do it at the staircase here. It will have everyone. Yeah, to me, I'm suggesting you do it here. Okay.
I suggest we do it here. Yeah. Great. Okay. Please follow Brian and Vinny. Yeah. Right now. Yeah.